Good afternoon, everyone. Welcome again to the Transplant Institute lecture series. We're very lucky today to have a good friend and a leader in transplantation in the United States and the world, Dr. Karim Abou-El-Maged, who's going to be talking to us today about the evolving field of gut rehabilitation. Many people know a little bit to not much on intestinal transplant and gut rehabilitation. And it's a very complex field. And Dr. Abou-El-Maged has been one of the early physicians, surgeons, leaders in the field from the 1990s. And subsequently, he saw that intestinal transplant was not enough of itself as an island. So he developed concepts on how to incorporate the comprehensive team in the care of the patient who has gut failure. And as a matter of fact, he coined the term and the concept of gut failure as a disease segment and how to incorporate it as a multidisciplinary team. He's very academically oriented, and he's originally from Egypt and got his PhD subsequently from Emory, and he has an extensive portfolio of research, over 500 publications. But his main contribution that us practitioners know about, in addition to the concept of gut rehabilitation, is working with the organ allocation system so that intestinal transplants and multi-organ transplants get allocated. They were not allocated the way you think they are. They were more of kind of on the margin. He also helped develop the DRGs, which is the way these procedures are termed and coined and paid for by national payers. So his influence goes beyond just the medical care and the care redesign into the regulatory arena. And Dr. Karim Abou-El-Maged has spent his core of his career here in Pittsburgh, and then subsequently went to Cleveland Clinic as the first director of the Cleveland Clinic Transplant Center. He's been there for 4 years, and he's telling me it was a little bit more challenge than he thought. And one of the things that I find exciting is that he came here to see how our Transplant Institute is set up and how we went about organizing our teams. And Dr. Abou-El-Maged, we're very happy to have you, and looking forward to your presentation.
Thank you very much, Marwan. You're wonderful, and we are proud of you and your accomplishment here at Henry Ford. And the first time I came to Detroit, actually, I came off the ship to Detroit in 1983, and spent about 6 months at Wayne State. So Detroit has been always a special city that close to my heart, although it was a very difficult time because it was in February of the snowstorm, and I used to, wearing the Egyptian shoes, so I slipped all the time, and they have fractures everywhere. So could I like to look at faces, so it would be entertaining. Nobody's going to take the food away from you. So if you can just move forward a little bit, because, don't forget I'm too old to see far away, and I'm going to feel that I'm talking to ghosts. So I want to talk to real people. And the reason I'm here today, really, to see all of you. I've been here, I think this is my second visit to your wonderful Transplant Institute. And, but the first visit was to learn from you how to establish an institute model in the world of organ transplantation, which it's a very challenging everywhere. The second visit today is to share with you really what we learned over the last 2.5 decades about small bowel transplantation. Having said that, I think transplantation is a small component of what we do nowadays and what I want you to do. And as I told the team in the morning, that I'm not here because I love Marwan, I'm here because I love the patients more. So I want you to focus with me And I hope I will give you what I have in my heart and my soul to deliver it and translate it to patient care, and forget about the politics. I have to say this, although I'm sick and tired of this slide, that the gut failure is the new terminology I use nowadays, and hopefully will be something that everybody will be aware of. That all patients before the 1960s, they used to die when they develop gut failure, which means they cannot survive without intravenous and parenteral nutrition. In the 70s, TPN came to play by Diedrich, which he's still alive. I saw him in Argentina, and I said, "Are you the one?" He said, "Yes." I said, "I thought you were dead." So we had dinner together, and the people, the surgeon, physician, took a lot of pictures of both of us, and saying, one loves TPN, one hates TPN. So, and then in the 80s, medical and surgical treatment of patients with short gut syndrome used to evolve, particularly in Europe. And in the 90s, we were able to introduce visceral transplantation. As you see, I don't call it intestinal transplantation anymore, abdominal visceral transplantation, as an alternative therapy to TPN. And then, after maybe a decade of experience, I realized that intestinal transplantation is not the only solution and should be the final or the last resort for patient with gut failure. The causes of gut failure are mainly short gut syndrome, about 80%, and then the rest, 20 or 30%, are dysmotility syndromes, neoplastic disorders, intrasite dysfunction, and portomesenteric venous thrombosis. And I made the slides, I think, maybe 20 years ago, because really nothing in the literature or in publication or the textbook telling us anything about gastrointestinal failure. Let's focus on the short gut syndrome as being the most common cause of gut failure. The causes of the short gut syndrome are quite different in adults than children, as you may all know. For those who are taking care of adult patients, usually vascular occlusion is the most common indication or cause of short gut syndrome, and indication for transplantation. Crohn's disease, the second leading cause, abdominal trauma, radiation enteritis, and surgical adhesions. My expectation that this arrangement will change because of the broader use of the word gut failure, but this came from our experience with transplantation. Please shut up. Okay. Okay. Here. In the kids, usually congenital causes, including gastroschisis, intestinal atresia, necrotizing enterocolitis, volvulus, etc., etc. From the Society of Gastroenterology, I stole this diagram showing the types of short bowel syndrome. You can see patients who lose the proximal jejunum. They have short gut syndrome, but they do the best, and they usually don't require intravenous nutrition. Type 2, when they lose the ileocecal valve with the distal ileum and part of the colon with the ileal resection. And part 3, which is usually a major issue, when they lose their distal small bowel and most of the colon, and that will be type 3. And type 4, which is the most devastating one, is a patient with ultra short gut syndrome, when the patient have massive thrombosis of the midgut, and then they really end with the stomach and duodenum, and that came to play when we asked for a national policy to cover small bowel transplantation with ultra-short gut syndrome as the most common indication, as one of the indications for the transplant. When for our surgical residents, if we have ones here, that once you resect a piece of bowel, the intestine go through the adaptation process. And early treatment is the key to enhance the adaptation process. This is a spontaneous adaptation process. Goes up to 3 years and beyond. But after 2 years, or close to 2 years, you have a plateau. And you must intervene here if you can. And then you could accelerate the adaptation process by early enteral feeding. And you even develop a state of hyperadaptation by manipulating the gut with medical treatment and intratropic hormones, as I will show you later. The mechanisms of the gut adaptation involve both the intestine and the colon. And you can see here in the animal study, when you do early enteral feeding, you see the villi is a lot better and more elongated. And if you do anthropometric measures, histological type, that you can see there is a lot of bigger surface area and more absorption of the intestine compared to those in TPN. And the colon or the large bowel also play a major role in the adaptation process by utilizing the bacterial products and short-chain fatty acids to produce energy. I should put this on the back or the end of the talk, but I put it up front to answer some of the demanding questions, how to establish a gut rehabilitation center. These are the components, they can see it, and I established or developed these slides after I moved to Cleveland for educational purposes, because really most of the time, as in everywhere in medicine, sometimes people don't talk the same language. And it's very hard for a new culture to understand your vision and what you really can do. So you have to use your different technical skills, including diagrams. Now you can see here you need surgeons, you need physicians, you need infectious disease who really understand the pathophysiology of the disease, nutritionists, which we have met with a few of you today, intensive care unit, that they really understand the complexity of these patients, social worker, nursing for inpatient, outpatients, and coordinators, radiology, they can help you with establishing a venous access to most of this patient, a pharmacist for immunosuppression, infectious, and nutritional care, laboratory to provide you with all you need, and more recently we established a component for the intestinal stroke surgery. Patient come referred with acute abdomen and mesenteric vascular occlusion if we can't save these patients before they develop gangrenous bowel. When you look at the management of gut failure, you really have to look at all aspects of the syndrome, from those with short gut syndrome with acid hypersecretion to those who have short gut with a rapid transit time, particularly those who lost the ileocecal valve, and with the loss of the surface area, to patients have intrinsic strictures and intrasite disease that needs to be treated aggressively, and also those who have the potentiality to be disconnected with a distal colon that is not utilized. And also, as you can see with patient with short gut syndrome, you have to manage the problem with bile acid colitis. So this should be well-known mechanisms of gut failure for both surgeons and physicians, as well as nutritionists, and the patient as well. The more you educate the patient, the more they listen to you, and the more they benefit from your expertise. So you have to connect with the patients all the time. These patients are very complex, very complicated, and they need you not just reading a book, but interact with them on a daily basis to help them out. First thing is the medical treatment. I think you can see here, that diarrhea is a major problem in this patient, or high stomal output. So imagine if you have to visit the bathroom for 15, 20 times, what quality of life you would have. So there is a cocktail of medical management from diet teaching to antidiarrheal agents, to prokinetic agents, to chelating agents, to pancreatic enzymes. It's a whole new field that most physicians and nutritionists also ignore. The recent advances in the medical management of patients with short bowel syndrome that started, as I can see it, in 2003 when I was in the panel with the FDA to approve the growth hormone as an enterocyte trophic factors. And we were able to approve it based on one fact. And then I told them that we have nothing to offer these patients, and anything we can do to avoid a transplant will be a success, and was approved. And then there was a lot of European bench studies on GLP-2, the glucagon-like peptides, that with a longer half-life that used to stimulate the enterocytes to grow and absorb more. And we were lucky also for the FDA to approve it in 2012. Both drugs are available in the United States. This called the Gattex, or the tiglutide, and for adults has yet to be approved for the children. And growth hormone is approved for both. The tiglutide is more effective than growth hormone, but also is more expensive. The cost for 1 year is about $200,000. Working with the European group, there is a GLP-1 analog that will be a lot less expensive than GLP-2. But at the present time, GLP-2 is usually available and really very effective in combination with other rehabilitative measures, including surgical intervention. The surgical management of patients with gut failure are primary three pillars. One is the autologous reconstruction, that you can put all the gut together and you utilize it properly. And the second one is, they call it structural reconstruction, when we can modulate the diameter of the bowel and the length of the bowel to absorb better and avoid the risk of bacterial overgrowth. And visceral transplantation, that's really the last resort as I see it. And I always tell the patient that nothing better than your own gut. Sometimes they get disappointed because they want to have a second thinking transplantation like going shopping. And then I scare the hell out of them and tell them that be patient until we rehabilitate your gut. If we fail gut rehabilitation, then we will transplant you. And what is his name? He's sleeping. Hello? Hey, why don't you go to the encore room and take a nap? Because are you going to make me sleep with you? All right. Now, thinking more and more how to teach the new generation to believe in gut rehabilitation, particularly the surgical one, we published this picture showing the surgical anatomy of the gut based on the embryological development. We have foregut, we have midgut, and we have a hindgut. This is important for teaching surgical techniques because the foregut, you have the celiac trunk or celiac artery that even my wife, she has nothing to do with medicine, know what the celiac trunk is. And then the midgut with the superior-mesenteric artery, and then the inferior-mesenteric artery to feed the left colon and the rectum. These are very important for organ retrieval, and also the map for the surgeon when you are inside the abdomen and you really cannot tell the difference between the stomach or intestine or large colon or pancreas or liver. You think I may be crazy, but that is true. Some of the patients where I have the surgeons with me, they really didn't know where is the liver, where is the pancreas, where is the intestine. It's so difficult sometimes. So you really have to know you have to have a GPS, or you know your anatomy to find your way without causing further damage. And based on experience on patients that have bariatric surgery that went sour, reconstructed a lot of them and published in the Annals of Surgery last September. And that is really the essence of the autologous reconstruction. What you can learn from this is surgical ingenuity. To use every single piece of the gut that's left there with vascularity. It reminds me of when we grew up, our grandmothers used to tailor the pajamas tears 100 times because we didn't have money to buy a new one. Or the Italian tailors who fix your trouser or pants because you want to use it more and more. So that is what it is. You can see here, you could spend 12, 14 hours in the operating room, reconstructed the gut. And you can see there's only one basic principle here, to maintain continuity of the alimentary flow. The food has to go through the natural pathway. I believe the duodenum is the major player and the central core of properly functioning gut. So as you can see here, pieces of a stomach I put together, and patients have gastric bypass with multiple fistulas. If I don't have enough stomach to work with, I use an interposition, jejunum and colon as alimentary conduit, preserving all the blood supply to these organs. And then, of course, if you have interrupted vagus, then you do pyloroplasty. And this is the different types of foregut reconstruction. And this is the mid and hindgut reconstruction. You can see you do multiple anastomoses to restore the continuity of the gut and utilize every single element of the small bowel. And then also the colon is the same way. Just to give you an example of a patient with Crohn's disease and hostile abdomen, and you can imagine how many abdominal operations this patient has. And by the end of the day, after 12, 14 hours, you feel good because you saved patients like this a transplant. They didn't need to be in TPN. They didn't need to require anti-rejection medication. They didn't have to give you a headache with rejection and finally lose the intestine and succumb to either retransplant or dying from infection. So it's really worth it. Another example, actually, I think is from Grant is from South Carolina. This is a Crohn's disease patient, and you can see. You would imagine how many hours I spent and saved every single piece of the bowel. I just saw him in the clinic this week. He looks fantastic. And that is the autologous reconstruction. Utilize every single piece of the bowel and put everything together, like building a house from scratch. The second component of the surgical autologous reconstruction is trying to lengthening the bowel, make the bowel longer. And then the first one is called the Bianchi procedure. You see Bianchi, he's still healthy and doing well. He retired now. He practiced in England. And he's a pediatric surgeon that kids who have a short gut syndrome develop bacterial overgrowth with huge duodenum and proximal jejunum. So what he did, he invented this procedure that the intestine has an anterior and posterior leaves. Then you can go in between and cut the intestine in two halves. Because the intestine is dilated, so you have enough diameter to split it in two halves. And then, as you can see here, so the diameter will be half of this, and the length will be doubled, and then they put them together. So you achieve two goals. One, you reduce the diameter of the bowel, so you reduce the risk of bacterial overgrowth. Number two, you double the length of the bowel, so you shorten the transit time. With both, you increase the capacity of the gut absorption and the enterocyte function. The second one, called serial transverse enteroplasty. Dr. Kim is currently at Mass General. I think he's a pediatric surgeon. He's become a transplant surgeon. He came with the idea when he was a medical student, making rounds with Dr. Pudar, and they were doing a nutritional support service. And he came with the idea, he said, if the intestine is so hugely dilated, why don't we do a zigzag cut? And that would shorten the length of the bowel, shorten the diameter of the bowel, or narrow the diameter of the bowel, or reduce the diameter of the bowel and lengthen the bowel. And it's a very simple procedure. And fair enough, I think it works very well. And I think I have done so far about 50 patients in Cleveland and about 20 in Pittsburgh. And the results are really very good, but you have to choose the right patients with no intrinsic disease, and also they have enough bowel to work with. And some patient, I did it 2 or 3 times. So the first time, and then the intestine becomes dilated again. You do it a second time 6 months later, etc. And the one patient, I did it 3 times on them. And the technique is very simple. Just the endovascular stapler, and you do the cuts, and you modify the technique to oversew them with fur or silk suture, because some of the staples you cannot trust. And also at the angle here, sometimes they have a minor leak and they presented with fever for a few weeks and then goes away. So realize that most likely because of this, and since then I didn't have any issues. And this is give you an example. You can see here no effect of immunosuppression. And this girl actually came to me in Pittsburgh about 8 years ago, and she was in a hospital in Florida for about 6 months. Nobody knows what to do with her. And that you can see how she's done very beautifully and graduated from the college, I think, a few years ago. What about those with dysmotility syndromes, neoplastic disorders, and enterocyte dysfunction? And you can see there's really nothing much you could do from the gut rehabilitation standpoints. We need something different than the tools we have now. So these patients should go straight forward for transplantation if they fulfill the criteria. With portomesenteric venous thrombosis, this is an important issue that these patients are very high risk, and occasionally surgeons abuse the multivisceral transplantation and do multiviscera on this patient that you can fix without a transplant. I'll give you an example here. If you have a patient like this, and in 1991, we used to transplant them because we didn't know any better. And also surgeons have the egotistical behavior sometimes. When we have a new procedure, we want to apply it to everyone, okay? But when you learn over the years, you learn that you really shouldn't do that. For our young generation, you should look for more innovative things to do for these patients. So this patient have preserved liver functions, and actually he was a paramedic, or he is a paramedic, and was 18 years old. And then you can see here, has a massive collaterals and gastrointestinal varices with a lot of mesenteric collaterals. This patient, you have to do something for them because you cannot endoscope them, you cannot do tips on them, and something has to be done. You have to decompress the system or transplant them. And with the preserved liver functions and good liver like this, I think it would be a shame to do a multi-viscera on them. So I took him to the operating room, and as you can see here, I was able to drain the coronary system, or the left gastric venous collaterals, through a interposition graft, Gore-Tex graft, into the cava, and you can see here the coronal-caval shunt, if you're familiar with it, with an 8 millimeter Gore-Tex graft, and you can see visualization of the cava and disappearance of the collateral that were here. To me, this is more appealing and more successful and more humanitarian than a multi-visceral transplant, with no doubt. I just saw the boy in Cleveland 2 weeks ago. Looks wonderful. Another thing you could do, the less transplant, the less organs, the better. There's no doubt about it. If you can do a liver transplant on those who are in liver failure, either with thrombectomy of the portal vein or another innovative procedure like the cavo-portal hemitransposition, it will be okay, although this type of the isolated liver in patient with recurrent variceal bleeding and extensive mesenteric venous thrombosis is not very successful in some of the patients because you did not really decompress the mesenteric venous system. But this is an example with the cavo transposition. You can see 11 years after transplant, I did very well, and you can see here the visualization of the inferior vena cava and the portal flow through the cava. But the problem is he was lucky, or he's still lucky enough, about 14 years now, that he never had recurrent bleeding. But as you can see, the portal system is still not fully decompressed. If we fail to do all of the above, then really you have to replace the engine, and you replace it with the abdominal visceral transplant. And I'm proud of you guys here. You have done 8 cases this year. And I think keep up with the good work. And just also in addition to number is outcome. So try to keep these patients healthy and alive and off TPN. If we fail gut rehabilitation, then visceral transplantation is the ultimate alternative to these patients. The reason I changed it to abdominal visceral transplantation, because it's not an intestinal transplantation. Intestinal transplantation is one type. It's isolated intestine. The yellow color, for those who are not familiar, with the small bowel transplant, combined liver and the intestine, and we usually give them the pancreas as a bonus because to maintain the integrity of the axial blood supply and the hepatobiliary system connected to the duodenum and the pancreas. And most of these patients, they have 2 pancreas, native pancreas and transplant pancreas. And then you get the full multi-viscera when you replace the liver, stomach, intestine, pancreas, and duodenum all together. Patient doesn't have colon or need a pull-through operation. I usually give them colon. Other than that, I do not give the colon as part of the transplant in a standard way. And then patients who have preserved liver functions, I usually preserve their liver and give them a stomach, the duodenum, pancreas, and the intestine according to the indication. So you have to tailor the type of organs needed based on what the really patient need and the indication, not what you can and you cannot do. For the isolated intestine, as we all know that in 1999 I approached Medicare, or HECFA at the time, and I established a standard criteria for isolated intestinal transplantation. A, to protect the patient from being transplanted unnecessarily. B, we have a good alternative therapy at the time was total parenteral nutrition. It's similar to the kidney. The patient can stay in a kidney on dialysis rather than have a kidney transplant. That was the notion early on in the 50s and 60s when the outcome were not good. So we were in a similar situation at the time, and I think it may be time now to modify these indications to be more liberal and transplant this patient before they develop all these problems. For the liver intestine, the most common indication are patients who develop liver failure due to the total parenteral nutrition and other associated pathology. Early on, a patient who have portomesenteric venous thrombosis with opened splenic vein, we used to give them liver and the intestine. For the multivisceral transplantation, patients have diffuse gastrointestinal disease, particularly global dysmotility disorders that extensively involving the stomach and the distal gut, as well as the small bowel. Patient with Gardner syndrome who have extensive desmoid tumor and extensive bulbosis of the gastrointestinal tract, and as we mentioned earlier, those who have extensive vascular thrombosis of the portomesenteric venous system associated with liver failure that you cannot technically give them isolated liver. Quickly, I'll go through the outcome, survival outcome with intestinal multivisceral transplantation to share it with you and to encourage our small bowel team here to keep doing the excellent work they're doing now and learn from the experience of others rather than reinventing the wheel, which we see it all the time. We're going to discuss the survival, the graft function, the quality of life, and cost effectiveness. You can see here, based on a 500 paper that some of you are familiar with, that the outcome, our experience in Pittsburgh, that the outcome has improved significantly over nearly 2 decades. And you can see early on, between 1995, the outcome was very poor, to the opposite what we thought. You can see the curve descending very deeply, steeply descending curve. And I respect this part of the curve more than anything in my life, because this would not exist without what we learned from these patients. I remember every single drop in this curve, the patient we lost. They stay with us all our life, and we must learn from them to help other patients. Then era 2, between 1995 and year 2000, when we introduced more immunosuppressive drugs to fight against rejection. And then era 3, that when we introduced the preconditioning or the induction therapy with anti-lymphocyte agents. You can see here the 1-year survival about 93, 94%, which is sometimes even better than the liver transplant. But this needs a multidisciplinary team. You need a driver to the bus, and you need a team in the bus that can learn and listen and follow the instructions rather than doing a haphazard care. The same thing in the national or the international data that David Grant used to run. It's published in the American Journal of Transplantation. And that also reflects the Pittsburgh experience, because we provided about 25 to 30% of the transplanted population at the time. As you can see here, the 1 year and 5-year survival has significantly improved over time, but becoming plateau after for over the last 5 years because of lack of any further innovative procedures in many ways. And these ways are the immunosuppressive protocols have been stagnant recently. The technical innovation, we did everything we could to avoid what the lessons we learned from the past. And post-operative management actually is going backwards. And the reason it's going backwards because most of the physicians or the surgeons who participated in developing the field moved around in a different culture that doesn't understand the need of these patients, and they don't want to understand sometimes. And you can't apply evidence-based medicine on these patients. You can't. You cannot. These patients are still, the field is still in the developing phase, and it's unfortunate, but things may go move forward. Then, if you can see the curve I showed you, after 5-10 years, a still continual descent in the curve. And I have a question, why? And the second thing, so if we know why, then we can make the long-term outcome better. And that's what's behind this paper that was presented at the American Surgical Association in 2012 and published in the Annals of Surgery. Here, what we found out unexpectedly, that you can see here that for patient survival, the most significant survival risk factor for these patients is poor social support. That's why when you evaluate your patients, don't rush to do more and more. Make sure the 12 hours you're spending in the operating room, it's worth a human life for another 20 years. Okay? So that's what we learned in the first 5-6 years of small bowel. We want to transplant to everybody, but everybody's going to die 5-6 years later. Why are we wasting our time and money and efforts and the human life? So you can see here, you have to pay great attention to the social support of the patients before you consider them for a small bowel transplantation. And the rest are well known based on previous publication, you know, rejection less than 90 days, we didn't use preconditioning or induction therapy. Female recipients are high risk because they are sensitized because of their pregnancy, et cetera, and they have a lot of donor-specific antibodies. And that was followed in another publication that I'm not sharing with you today, that the detrimental effect of donor-specific antibodies in outcome. And then retransplantation, also, as with any other organs, is a risk factor. And recipient age more than above 20 years of age, because the kids are very resilient. They have good body reserve. They're not abused like the adults, and their outcome is always better. That's why if somebody asks me, what should I start if I'm starting a small bowel program? I said, start with the kids first. For the graft survival, the liver is the central core of better outcome. It doesn't justify replacing liver all the time with the intestine because of the short in the demand, and also because of your commitment. If something happened to this patient, you either retransplant them or die. But if you give intestine alone, you can always take the intestine out and put them back on TPN and give them a second trial. So the liver is a great organ. That's why Marwan fell in love with it for how many years now? 20, 30 years? 25 years. You're that old? I thought you were young. All right. So, but definitely the liver protect any organs that transplanted. Most particularly from the same donor. So patient who had a liver intestine, they do a lot better than intestine alone, although the recovery is slower, and there is no alternative when they have a failed graft except retransplantation, but once they fly, they fly. Splenectomy is also a significant risk factor because of the overwhelming sepsis, PTLD as expected, rejection, and HLA mismatch reach to some level of significance, not based on the p-value, but you can tell there is definitely a trend. What about graft function, the second variable? You can see the nutritional autonomy is achieved in more than 90% of the patients who have the graft in place. So you really, if you successfully transplant these patients within 1 to 2 weeks, that you can take them off TPN. And the rest, 9–10%, either they have chronic graft dysfunction or they are going through a phase of rejection and they require temporary intravenous nutrition. You can see that actually we make most of these patients, I wouldn't say the bad word because of Trump, but you can see that the body mass index increases after transplant to the extent some of the patients, they ask me if they can have bariatric surgery. Even worse than that, 2 of them that they lost the intestine due to bariatric surgery, they want me to approve them to get another bariatric surgery. I said, on my dead body. That's true, what I'm telling you. So, but you can see here the quality of life after visceral transplantation has improved significantly when you have a successful graft. Based on the global health scale, Karnofsky for the adults and Leniski for the kids, about close to 90% goes back to normal life. Major problem in these patients is because of the disability issues, and I put it in one of the papers for the government to look at it, is they're afraid to go to work. They can work, but they're afraid to go to work. They're going to lose their insurance. And if they get in trouble a year or 2 years later, they have no insurance to cover them. So it's a shame. But now also trying to tease our gastroenterologists or that who opposing small bowel transplant, that as you can see here, get the group of patients that did a surveillance quality of life domains study on them before and after transplant. Those definitely all of them on TPN before transplant, and those who had a transplant. You can see if you have a higher value here, indicates impaired quality of life. So these the red bars are the TPN patients before transplant, and the blue are the same patients who came off TPN after transplant. You can see there's significant improvement in all domains except the depression. The depression was a significantly worse after transplant versus before transplant. And you can imagine if you don't carry your own intestine, or you are at a risk of rejection all the time, and Karim annoying you all the time, or the physician who's taking care of you. So sometimes, and also sometimes they lose the social support. So I give them a depressive thing. I'm going to close very soon. Quality of, cost effectiveness, and this was 1999, and shortly before, or shortly after I published this paper, I went to Medicare because we know dollars talk. And I proved in this paper that within first 2 years of transplant, that the transplant, small bowel transplant, is cost effective. And that was one of the documents I provided to HECFA at that time. The unmeasurable thing, not the cost effectiveness, and how to make these patients live normal life. You can see here, I'll give you an example. Gina, she is a French girl. The Goulet and the group transplanted her when she was, I think, 8 months or 9 months. Now she is 27-year-old here. And at this picture, you see she doesn't smile because of gingivitis from the cyclosporin. I talked to Oliver Goulet, switched her to Prograf after we introduced the Prograf in the 90s, and she's 27-year-old now. Also, Teresa, now she's doing very well. She's a teacher now. We transplanted her, I think she was 2 or 3 years old, and now look at her now. She is a teacher. She's doing very well, and you can tell she is in love with me, but I was taken. Also, some of these patients, they got married and they were able to have kids. Judy here, she's from Ohio. She has 2 kids now. They are about 8 or 10-year-old now. And we were in a reunion in Pittsburgh. This is, if you don't know, this is Dr. Starzl. He was drunk, and my wife just don't to say that. And that is Dr. George Mazariegis, my colleagues who is running the pediatric program with me. And you can see also this wonderful girl from Atlanta. I transplanted her, and actually I saw her in Cleveland a few months ago. Her son now is about 4 years old. And you can see here a lot of examples. And this is 4 members from the same family. They have Gardner syndrome, uncle, 2 brothers and niece, and they're all doing well. Actually, Craig is totally off immunosuppression now for about 8 years, and didn't have time to even write him up. Khalid, he is a Palestinian boy living in Israel. And I went recently to visit the team there. He's about 3 years out now. And the only survival was Martina-Fry syndrome. Beyond all of them die at the age of 10 months. He survived to 2 years and came to me, and we transplanted him. The Martina-Fry syndrome is a neonatal diabetes, gut failure due to enterocyte failures, and cholestatic liver from iron overload and some other metabolic abnormalities. So I gave him a liver, intestine, and pancreas. And he's about 3 years out now, I think. And he's the most intelligent boy I have ever seen, really. And we have a movie on him on the internet. And I visited him in Israel recently, and he usually teaches the teachers and started the school this year. And his wife told me that he's trying to teach the teacher how to teach. If you are interested in the field of gut rehabilitation, you must and you should read this paper in the Nature Review. I spend a lot of time on this because I think that's holding the future of the field. One thing in the end of the paper showing how to manage patients with gut failure. If you have acute gut failure, you should have intestinal stroke initiatives immediately. And if you save the intestine, fine, and you achieve nutritional autonomy or maintain the nutritional autonomy. If not, you go medical and surgical rehab after the resection. And if you achieve nutritional autonomy, fine. If not, you go visceral transplant. Patient with chronic gut failure, you have a short gut syndrome, you go medical and surgical rehab. You fail, you go transplant. Those with functional neoplastic and vascular disorders are most commonly or are not a candidate for gut rehabilitation, and you go visceral transplant. Don't wait in these patients until they develop a lot of issues. And if you ask me by the end of my talk why I had interest and wasted my whole life in the field, because I believe in what Josh Belling said more than a century ago, that I have finally come to the conclusion that a good, reliable set of bowels is worth more to a man than any quantity of brains. The 2 comments I have in this statement: 1, he didn't mean just man, he means man and woman. And number 2 is all this is a phonetic language is not a typographic error. Thank you very much for your attention.